Welcome to Native America Calling. I'm Sean Spruce. From small storefront clinics to multi-billion-dollar operations, the Indian Health Service is a key healthcare provider for Native Americans, especially those living on or near reservations. Its advocates praise its reach as a lifesaver for millions of enrolled citizens. At the same time, they complain about the system's chronic shortage of funds from the U.S. government. Today marks the 70th anniversary of the founding of IHS. We'll chart its evolution in that time and the direction for the agency in the near and far future. We're back after the news.
This is National Native News. I'm Antonia Gonzalez. A federal audit has found that the Environmental Protection Agency did not distribute millions of dollars on time to clean water programs for tribes. As the Mountain West News Bureau's Caleb Radel reports, this comes as tens of thousands of tribal homes lack indoor plumbing and clean drinking water.
The agency's own inspector general examined more than $300 million from the bipartisan infrastructure law that was supposed to go to tribal water programs over 2 years. In the 2022 fiscal year, more than half of the funds allocated had not been awarded on time. And in 2023, most of the remaining water project funds did not get distributed. The audit cited that the Indian Health Service estimates about 41,000 tribal homes lack indoor plumbing, and thousands lack access to safe drinking water.
So these funds are really tailored to addressing those problems. Funds for designing and constructing wastewater treatment facilities, improving drinking water systems, and addressing emerging contaminants.
That's Marcus Gullett with the Inspector General's office. The EPA acknowledged in a final report that it made mistakes in most cases and said it would work to fix them. It agreed to focus on improving the timeliness of providing funds to tribes. I'm Caleb Radel.
Navajo Nation leaders are urging residents near the Oak Ridge fire to remain vigilant and follow emergency protocols and evacuation alerts. The fire is burning on the reservation near St. Michael's, Arizona. Residents in at least 3 communities were evacuated on Sunday. As of Tuesday morning, the fire was at more than 9,000 acres with zero containment. More than 150 people recently gathered in America's northernmost community for the Migratory Bird Festival. KNBA's Alaska desk reporter Ayolna Naiden has more on the festival and the rapid growth of birding tourism in Alaska.
A little brown bird walks and chirps along the still partially frozen Utkahovik Lagoon. It's a semi-palmated sandpiper, one of about 60 species that locals and visitors spotted during the Migratory Bird Festival. Lindsay Hermans is the festival's coordinator. She says avid birders often travel to the Arctic to see rare species that fly here from all corners of the world. But sometimes it's even more exciting to see familiar birds in their breeding grounds, where they wear totally different plumage.
It's like a glow up. They look totally different. They're flying around, they're doing their mating displays and exhibiting this behavior that you only see in the Arctic.
Attendees rode around in school buses for several hours, spotting different birds and talking about Inupiaq culture, Utkahovik history, and the Arctic environment. Herman says that the main goal of the free 3-day festival was to show how important the Arctic ecosystem is for the birds. But the highlight for her was what the participants brought to the table. Several elders came to the talks and commented on what birds they harvest, how they do it traditionally, and what they call those species in Inupiaq language.
That was a major component of success in my mind, is having the elders be involved like that.
Local knowledge holders and Inupiaq speakers also participated in creating new Utkahovik Birding Trail, a brochure that spotlights 10 sites throughout town where you can see birds in breeding plumage. As the Arctic warms, forests shrink and hurricanes intensify, migrating to the Arctic becomes more difficult. This is Lauren Cosimano with Audubon, Alaska.
Utkahovik becomes even more important for shorebird species because once they get there, they can do their thing.
Herman says she hopes more Arctic residents will get involved in organizing the event in the future. I am Alona Naiden.
And I'm Antonia Gonzalez.
National Native News is produced by Kawanak Broadcast Corporation with funding by the Corporation for Public Broadcasting.
Support by Arctic Encounter 2025, July 30th to August 1st in Anchorage, Alaska, to shape policy, investment, and innovation in the far north. Registration at arcticencounter.com, who support this show. Support by Drummond Woodsum, a full-service law firm whose nationally recognized tribal nations practice provides services to tribal nations and their enterprises and to companies that do business with tribes across the country. More at dwmlaw.com.
Native Voice One, the Native American Radio Network.
This is Native America Calling. I'm Sean Spruce. In its 70-year-long history, the Indian Health Service has been one of the most direct connections Native Americans have with the trust and treaty responsibility of the United States. And all that time, the people who practice at IHS facilities say it has not been funded at the level that meets the need. And just within the last hour, the U.S. Senate passed what's known as the Big Beautiful Bill. It includes cuts to Medicaid, among other programs, which have major implications for people who rely on the Indian Health Service. Today, on the anniversary of 70 years of IHS, we take stock of the agency's vital role in Native health care and learn about what is in store in the months and years ahead. We also want to hear from you today, our listeners. What are your thoughts on the legacy of the Indian Health Service? You can join us with a comment or question by calling 1-800-996-2848. That's also 1-800-99-NATIVE. Joining us now from Anchorage, Alaska is Benjamin Smith. He is the acting director of the Indian Health Service and a citizen of the Navajo Nation. Good morning, Benjamin, and welcome to Native America Calling.
Good morning. It's a pleasure to be here with you. I'm looking forward to today's call.
I am too. Joining us from Rapid City, South Dakota is Dr. Donald Warren. He is the co-director of the Johns Hopkins Center for Indigenous Health. He is Oglala Lakota. Good morning to you too, Dr. Warren, and welcome back to the show.
Thank you so much. It's wonderful to be here.
Joining us from Chicago, Illinois is Mary Smith. She is the former CEO of the Indian Health Service. She's a citizen of the Cherokee Nation. Mary, welcome back to Native America Calling.
Thank you. Great to be here.
And joining us from Phoenix, Arizona is Michael Yaqui. He is a retired Rear Admiral in the U.S. Public Health Service and previous director of the Indian Health Service. He is Zuni Pueblo. Michael, good morning and welcome to the show to you as well.
Good morning, Sean, and thank you for having me.
Absolutely. Well, I want to begin with Benjamin Smith. Benjamin, can you begin with a brief assessment of the Indian Health Service as we mark the 70th year of its founding? What are some key accomplishments over the past decade?
Well, thank you very much for the question. As we contemplate the 70th anniversary, since the Transfer Act moved operations from the Bureau of Indian Affairs over to the Indian Health Service, we have so much to be grateful for and accomplish, from the expansion of access to life-saving healthcare in some of the most remote parts of the country, to addressing healthcare operations and services to the overwhelming amount of American Indians, Alaska Natives that reside in urban Indian organizations. But most importantly, I would like to acknowledge the government-to-government relations between the federal government and Indian tribes that has evolved over this 70-year period. Of course, it didn't start just in the past 70 years, but it has really transformed Indian health care today as tribes and tribal organizations are exercising their inherent right to self-determination and self-governance to operate those programs, services, functions, and activities that the federal government would otherwise provide. In fact, today, over 60% of our Indian Health Service appropriated budget is now tribally managed and operated. So I'm looking forward to getting into some of those accomplishments, but those are some of the highlights that I would just bring to your immediate attention.
All right. Thank you, Benjamin. Well, tell us more about what the mission of the Indian Health Service is right now today. And is the United States living up to its trust responsibility?
Thank you for the question. I like to say Indian Health Service has the best mission in federal government and probably perhaps any organization. Our mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. And as we work to fulfill our statutory requirements in providing healthcare services, we're entering into agreements with tribes and tribal organizations. We take that very serious. As you may have heard, there are numerous challenges out there that we confront on a daily basis relating to chronic underfunding of the Indian Health Service, some of our workforce shortages, our aging facility infrastructure, and extending some of the specialty services to all American Indians and Alaska Natives. But in our partnership with tribal governments, we are able to accomplish a lot and learn from one another as governments to move our agenda forward. And so I would like to get into some of these areas if we have time today, but we'll look to your direction. But we are a mission-driven agency, and with a workforce that's comprised of over 70% of its 15,000 employees who come from American Indian and Alaska Native communities. So this is personal for us, and we take the work we do very seriously.
Thank you, Benjamin. Let's talk about this breaking news. The U.S. Senate just passed the comprehensive spending bill offered by the president, and there are major cuts coming to Medicaid. More than 1 million Native Americans and Alaska Natives are enrolled in Medicaid, and in numerous interviews, leaders of IHS facilities across the country do predict a significant reduction in services to Native patients. Benjamin, what message do you have for IHS patients about what is coming here in the coming months and years?
Well, as we know through the legislative process, there are multiple steps, including laws being enacted. So we are looking forward to the law and being able to have opportunities to review that and its impact to the Indian Health Service. What I can say, though, is our entire health system, that being the Indian Health Service and tribal health programs and urban Indian organizations, we are the 18th largest health system in this country. And so any resources that are coming into the system as a whole help us to expand healthcare service access and delivery. It helps us to improve upon our quality. It helps us to build and maintain operations in our facility footprint across this country. And so what I've heard nationwide from tribes, from our federal sites, as well as others, that the benefits that have come in through the resources of Medicare, Medicaid have been prudently used and have been able to bring life-changing improvements throughout our system, despite the underfunded or chronic underfunding that we've sustained for multiple decades.
I want to ask you about Health Secretary Robert F. Kennedy Jr. What tangible actions have you seen from him to demonstrate that he has a firm grasp on what the Indian Health Service does?
Thank you for the question. From day one, Secretary Kennedy immediately stepped up to the plate and reinforced across the department the commitment of the department to Indian health. And he's done that by stepping in and ensuring that our workforce can continue as the new administration comes into play. With the launch of the Make America Healthy Again initiative of this administration and this department, we know that aligns perfectly with the mission of the Indian Health Service. We want to prevent disease, reduce chronic conditions across our system. In fact, one of the biggest challenges we have is just looking at average life expectancy. We are 10.9 years shorter than the U.S. general population, and this is almost equivalent to the U.S. all in 1944. So we definitely have a lot of work to do. But Secretary Kennedy has immediately engaged with tribal partners. He has met with his secretary's tribal advisory committee twice. He has already made visits to Indian country, both from at my tribe at the Navajo Nation, as well as visits in both the states of Arizona and Oklahoma City. So we look forward to working with him, and he does bring extensive knowledge just from some of his past work in the private sector.
I also want to ask you about Senator Lisa Murkowski from the state you're in right now, Alaska. Now, she says the termination of staff who manage tribal health programs in Indian country, in her words, threatens the health, safety, and well-being of Native communities across the country. Benjamin, do you agree with that assessment?
I would say any termination of any employee at this time is not helpful to any system. In fact, at Indian Health Service, we're carrying a 30% vacancy rate. We need every employee, and we welcome every employee to our system. In fact, throughout this administration, as they're onboarding, there's a federal hiring freeze. The Indian Health Service has been successful through the leadership of Secretary Kennedy and working with the White House, the Office of Personnel Management, to ensure that we have limited exemptions to hire some of the most critical healthcare providers throughout our system. So we continue to onboard staff, but that is the message I want to get across today, is that the Indian Health Service is recruiting. We are looking for talent. And please bring your talent to the Indian Health Service.
All right, we got about a minute. I can ask you one more question, Benjamin, before we go to break. Tell me what you see for the future of the Indian Health Service, and how can it improve with less money and fewer services going forward?
Indian Health is constantly evolving. In fact, as I mentioned in just my opening comments, today over 60% of our operations are now tribally operated and managed through the authorities of the Indian Self-Determination Education Assistance Act. We do look different today, and we do need to modernize. We do want to position the agency for the next 7 generations to come. And what that means is we need to lead in healthcare. We need to deliver high quality, culturally responsive care as a direct healthcare system. Secondly, we need to run efficient and accountable operations, ensuring that our HR, our acquisitions work seamlessly across our system. And most importantly, we need to continue to support tribal sovereignty and partnerships. And we take that serious. So we look forward to working.
We're going to have to take a short break, Benjamin. I'm sorry. We'll be right back. The U.S. Supreme Court just ended its term with rulings that have implications for Native Americans. One sends a vague message on birthright citizenship, an issue that is connected to those who are tribal citizens. Another prevents judges from using a local issue to stop an action happening on a national scale. We'll find out how those will play out from a Native perspective on the next Native America Calling.
Support provided by Amerind. Amerind is 100% tribally owned and partners with tribes and their businesses to provide affordable commercial insurance coverage, protect tribal sovereignty, and strengthen Native American communities by helping to keep dollars in Indian country. Information about property, liability, commercial auto, and workers' comp available at amerind.com. That's AMERIND.com.
Thank you for listening to Native America Calling. Today marks the 70th anniversary of the establishment of the Indian Health Service. We're getting insights from several current and former officials of the agency, as well as Native public health experts about the history of healthcare for Native people in this country. We also invite you to the conversation, our listeners. Are you an IHS patient? If so, what changes have you seen in recent years? Do you think the healthcare you receive at IHS now is better than it was 10, 20, or maybe 30 years ago? Let us know at 1-800-996-2848. That's also 1-800-99-NATIVE. We have Benjamin Smith on the line in Anchorage, Alaska. He is the acting director of the Indian Health Service. And Benjamin, I apologize. Sometimes the breaks on this show, they come up pretty quickly. You were talking about the future of IHS. I want to give you a chance to finish your thoughts there before we move on to the next guest.
Yes, thank you very much. The point I want to make is that our system is for our patients, our relatives, and so every voice matters. So as we move forward in looking at what the Indian Health Service is evolving into, we do need the input from tribal leaders, from urban Indian organization leaders, as well as our patients. We are a system that serves 2.8 million American Indians and Alaska Natives from 574 federally recognized tribes across 37 states. That is a very diverse and complex system, and every voice matters. So recently, I initiated tribal consultation and urban confer to start receiving input from tribal leaders, from urban Indian organization leaders across the system. We need your input to make sure that we are keeping patients at the heart, whether this is improving IT systems, information technology systems, our clinical care access, or even sharing recommendations on what's working best in your communities. But with that, let's all keep patients in our heart as we celebrate the 70th anniversary of the Indian Health Service. And it's been a pleasure being here with you. You have a great panel, and thank you so much for inviting me to today's call.
Thank you, Benjamin. Appreciate you taking the time. Enjoy the rest of your day, okay?
Thank you.
Let's hear now from Dr. John Molina. He is the director of the Arizona Advisory Council on Indian Healthcare. He is Pascua, Yaqui, and San Carlos Apache. He's held numerous leadership positions in his 30-year-long medical career. He also spent 10 years as a OBGYN physician at the Indian Health Service. He spoke to us over Zoom about the long-standing issues at IHS.
There's really been no significant improvement in Indian health status. Speaking personally myself, as I see that we still have the highest morbidity, mortality rates that we have seen. Suicide, substance abuse, substance misuse, chronic disease, all these issues are plaguing us and have been, I think, since the Indian Health Service was established. Now, I can say that it's of no fault to the employees who work at Indian Health Service. They do their best. I myself was an attending physician, OBGYN doctor at Phoenix Indian Medical Center for about 10 years. And during my tenure there, I saw the passion of our people, mostly Indian people who work for the Indian Health Service, that were committed to doing the best they can with what they had. One of my surgeon friends actually had to design his own surgical tool because the hospital couldn't afford to buy new equipment. About 5 years ago, the obstetrical unit was closed because the obstetrical unit was needing some really bad repair and upgrades, but the hospital didn't have the money. Congress won't appropriate the money. So now our Indian people are being delivered at a private hospital in Phoenix. And this really, for me, impacted me personally because our Indian people really appreciate the fact that there's an Indian hospital where they feel comfortable, where they're treated and taken care of by their own, rather than having to drive across town to a, with all respect, white hospital to get their care. So I think in some ways, I think Indian Health Service has advanced both in improving quality, efficiency, safety for patients, but there's still a lot of facilities that need to be replaced, staffing that needs to be upgraded, a lot of vacancy rate. I think the vacancy rate right now can go between 40 and 60% because there's a lack of money. Also, the salaries are not competitive to the Western world, so we lose a lot of staffing that go out, and because they need to take care of families, they can make a better living working at non-IHS hospitals. So I really give a lot of credit to those who work with Indian Health Service because what guides them is a passion for their people.
That was an interview with Dr. John Molina, the director of the Arizona Advisory Council on Indian Healthcare. An extended version of that interview will be made available on our website, www.nativeamericacalling.com. Let's hear now from Dr. Donald Warren. He's the co-director of the Johns Hopkins Center for Indigenous Health. He joins us now from Rapid City, South Dakota. And Dr. Warren, I just can't get over it. 70 years, that is a really long time. And I think some elders might remember how different the Indian Health Service was back in the 1950s compared to now. Can you tell us more? In what ways has IHS changed for the better over the decades?
Yeah, and it's a fascinating history. As Mr. Smith had mentioned previously, prior to the Transfer Act, the Indian Health Program was operated within the Bureau of Indian Affairs. And so I'm 58, so I wasn't around when the Transfer Act occurred, but I've talked to a lot of former patients who were patients of the Indian health system before and after the IHS was developed. And previously, there were less facilities. Quite often, there were makeshift areas for clinics, and people talk about the forms that they would get to take to the doctor to get diagnosis and treatment, and everything was, of course, done on paper. Very limited access to services and healthcare. So, going back to that point, prior to 70 years ago, we did have even worse health status. We had shorter life expectancy. Infectious disease in particular was just rampant and a huge problem. We know with a long history of things like smallpox, but we also had to deal with influenza, Haemophilus, influenza B, many other infectious diseases. So once Indian Health Service started, and there was also a focus on sanitation and improving the water quality and those types of things in our communities, we did see improvements in health status and life expectancy. So kind of fast forwarding to today, and also kind of linking to what Mr. Smith had mentioned, the system's evolved tremendously since 1955. And in 1975, of course, was the Indian Self-Determination Education Assistance Act. So that's now 50 years old itself as of this year. And we've seen tremendous improvements in tribal management of healthcare systems. And in my own experiences as a physician, I've worked for both IHS and tribal facilities. And again, this is back in the 1990s, but what I experienced is that the tribes had a lot more flexibility in terms of things like developing the medication formulary and the types of drugs that we had access to. And I was also working at Phoenix Indian Medical Center, which is the largest IHS direct care facility. And in my own experience, what I found is that I had access to more tools under tribal management than I did under federal management. Now, that's not the fault of IHS. It really is largely due to underfunding and needing to comply with federal rules and regulations, like with medication formularies and that type of thing. But the tribes have a lot more flexibility. So we've seen just tremendous improvements in terms of public health and health outcomes. Unfortunately, in recent years, we've seen some steps backward because of COVID and other considerations.
Mm-hmm. Dr. Warren, we heard earlier in that pre-recorded interview with Dr. Molina, who mentioned various inequities facing IHS and said they've existed since the very beginning of the agency. How do these inequities continue to persist?
Yeah, that's a really complex question. And we do see some communities with some significant improvements. But in truth, a lot of the challenges that we face across the board relate to unresolved and complex trauma, whether it's historical trauma or adverse childhood experiences or the legacy of boarding schools. I don't think that we've resolved those things. And part of the solution, obviously, is access to health services. We need a fully funded Indian Health Service. But part of that has to include the public health approach and prevention and addressing mental and behavioral health from a more culturally relevant manner. And I think we just have unique patterns of unresolved trauma in Indigenous populations as a long-term intergenerational impact of colonization, marginalization, the taking away of culture and language, and all of those things that occurred have not been fully resolved. And that's why we still see inequities. Again, we've seen tremendous improvements from 70 years ago, but we have a long way to go to get to health equity for our populations.
Dr. Warren, what's been the most effective initiative or program by the Indian Health Service that has successfully addressed a specific healthcare need for Native patients? What have you seen?
One thing we can be very proud of is in public health nursing and the pediatric vaccination rates. And there were data, 10 years ago and prior, that among the highest percentages of pediatric vaccination rates were among IHS patients, because the public health nursing systems were so effective, and they're really the frontline workers. We have seen some pullback just nationally, unfortunately, with vaccine hesitancy and misinformation about vaccines, but historically, we just saved an untold number of lives and prevented so much suffering through pediatric vaccination rates. And just real briefly, the Haemophilus influenza B bacteria can cause epiglottitis or meningitis And these types of illnesses are not where a child just peacefully passes away. These are high fever, a lot of pain and suffering before death. And this was not uncommon in our communities, but due to vaccination, we've prevented just untold thousands and thousands of deaths and suffering. And really the IHS Public Health Nursing Program has just been at the forefront of that effort.
A few minutes ago, I asked listeners to give us a call if they themselves are IHS patients and if they think the healthcare they receive at IHS has improved over the years. And I want to ask you that question, Dr. Warren, because you've been an IHS patient. I don't know if you still are, but I know at one point you're from Pine Ridge. And what's your thought as a patient of the Indian Health Service? Has the healthcare improved? And if so, what do you attribute to?
Of course, every site is unique and every person's experience is unique. But for me, I just remember as a child, when I would engage the IHS system as a patient, I rarely saw the same provider. Typically, there were people rotating in and out as temporary providers and that type of thing. And we still see that now. But one of the things that I find very encouraging is the numbers of American Indian and Alaska Native physicians and other healthcare professionals that are working within our systems. And we have not resolved that problem. We still have a significant disparity, but it's much better than it was 20, 30, 40 years ago. But moving forward, we really do need to also focus on workforce development and make sure that we have Indigenous medical training programs, but also we should have a whole series of residency and fellowship training opportunities within IHS and tribal programs. So I've seen a lot of improvement, particularly when we have cultural concordance. If the doctor is Native, that is actually correlated with improved quality of care because of that cultural connectedness. So we have seen those improvements, and I've witnessed that in my own lifetime and experience. But again, we still have steps to take to fully resolve that disparity.
Let's go to the phones where we have Bill listening in South Dakota on station KXSW, Siston Wapton. Hello, Bill. Welcome into the show.
Hello.
Bill,
Hey,
I understand
Bill.
you worked at IHS.
Yes, I worked at IHS as the urban health administrator of all the urban Indian clinics located throughout the major cities of the U.S. for Indian Health Service. I did that in the early 90s.
Early 90s, okay.
And I also took my, it's called Community Health Medic Training in the 70s, where IHS trained us to be like physician's assistants in the remote areas of reservations. So I did that for numerous years for Pine Ridge and Shoshone Bannock in Idaho. So they provided health care. They trained us to do our lab work, our x-rays, to do preventive emergency dental procedures. It was very, very intense, and then we could write prescriptions also to help regular medical doctors.
Well, Bill, what's your thought on the evolution of the Indian Health Service? Here we are, 70 years.
Well, I really support everything the leadership, the past leadership that I previously just right to me be on in here. I respect all their comments and everything. But my concern is that for the past 50 years, Title 25, Chapter 18, Indian Health had diabetes section in there for prevention, treatment, and control. And Part D of that law, that's still legitimate law, allowed for tribes to have dialysis programs. I'm really disappointed in Indian Health Service, Department of Health and Human Services. Is the Inspector General in 2011 did a report on IHS and tribes' access to dialysis for tribal members. In there, out of 506 tribes, only 8 provided any type of services, but not direct dialysis programs. So my charge is I went to our tribal council, got a resolution passed, and I'll be going to the National Congress, National Indian Council on Aging, to present that resolution for all tribes to unite, to go to Congress and try to get appropriations to fund that badly needed dialysis program.
All right, Bill, thanks for calling in. Dr. Warren, I'd like you to respond to that. The caller, Bill, mentions diabetes prevention and also dialysis. And dialysis really struck a chord with me because I have a relative who just went on dialysis about a month ago, and it is really, really, really costly. I just can't get over how much it is every day for this relative. What are your thoughts there?
Yeah, prior to the reauthorization of the Indian Healthcare Improvement Act back in 2010, dialysis services were not one of the line item budget components of the Indian Health Service. Other things like even long-term care was not in the line item of services. So that we do now have authority to develop these programs, but because of underfunding, unfortunately, Congress has just never funded these programs. So that's why we have very limited local access to dialysis services. So a couple thoughts on that. One, when you are in end-stage renal disease, that's an automatic eligibility for Medicare, no matter what your age is. So that's another funding source that can be leveraged, but it still needs its own resources within the IHS budget to fully support dialysis. So I totally agree with that. The other piece of it, I'm glad he also mentioned diabetes prevention, because not only is type 2 diabetes preventable, but for people with diabetes, renal failure is also preventable. So we need a really comprehensive approach with public health and preventing diabetes, but also medical management to control diabetes and prevent kidney failure.
All right. Dr. Donald Warren, co-director of the Johns Hopkins Center for Indigenous Health. We're going to take another short break. We're going to come back and we will speak with Mary Smith, former CEO of the Indian Health Service, and also Michael Yaqui, previous director of the Indian Health Service. Stay with us.
Challenges to societal harmony abound. Trauma, depression, addiction. In Native communities, these challenges affect nearly everyone. The Native American Social Work Studies Institute educates social workers for careers to address the needs of Native communities. You can be part of the solution as a peer support worker, community health worker, or a counselor with culturally relevant training from the Native American Social Work Studies Institute. Info at online.nmhu.edu. New Mexico Highlands University supports this show.
You are listening to Native America Calling. We're discussing the history of the Indian Health Service. We'll talk about the history of programs and services the agency provides and the challenges it faces with providing care. There's still plenty of time. If you would like to join the conversation, you can share comments and questions at 1-800-996-2848. 1-800-996-2848. Mary Smith joins us now from Chicago. She's the former CEO of the Indian Health Service. And Mary, thank you again for joining the show. And I want to talk about an initiative that you were a big part of. You headed the agency from 2015 to 2017. And during that time, you created what's known as a quality framework for IHS facilities. Can you tell us more about that? Explain what that means and the motivation behind it.
Yeah, well, thanks so much for having me. I'm really glad to be here to celebrate the 70th anniversary of the Indian Health Service because it provides so much needed care to tribal communities and urban Indian communities. When I was there, one of the initiatives was creating this quality framework, and quality is an initiative in a department at all health systems that provides standards such as like infection protection and control and other procedures that allow a hospital to be safe. And it was very important to create this initiative. We also created the position of the Deputy Director of Quality. That IHS did not have that at the time. And we tried to make there's 26 IHS hospitals, to make them all adhere to the same standards and to be accredited to provide services to tribal communities.
All right, now it's been about 10 years. Do you have a sense of how that framework is holding up?
Well, I do see that, the Deputy Director of Quality is still in position, and I think they have been implementing it over the past 10 years. So I think it's progress moving forward. And I think the one thing that I was always struck by the Indian Health Service, I know I tried to send this message to our staff who I know believe passionately in the mission, is that you constantly strive to do better because that's what our patients deserve.
Mary, you and our other guest, Michael Yaqui, worked together on improving the Rosebud Emergency Clinic at a time it needed to regain its accreditation. Tell us more about that experience and what did it take to make sure that those quality standards were met?
Yeah, while I was there as head of the agency, there were many challenges, as there continue to be. There's a lot of bright spots, but there's always challenges. And some of the challenges we had during the time I was there before I became director, there were citations from CMS, which is the Centers for Medicare and Medicaid Services at HHS, which accredits hospitals to be able to be reimbursed by Medicare. And the Rosebud Hospital and also the Pine Ridge Hospital had received some of those citations, and the most severe one is in immediate jeopardy, and they were issued for both of those hospitals. And I just put all hands on deck because that is unacceptable. Our patients, Native American people, deserve the best health care they can get. And I was really fortunate that Dr. Yaqui, I asked him, and he did not hesitate. I said, I think we need someone to go out to Rosebud and be there to see this through and to ensure that we get up to standards so that we will be able to pass our next inspection. And he, without hesitation, went out there for several months and was able to turn that hospital around. So I'm eternally grateful to him.
All right. Well, let's get Michael's perspective on that. Michael Yaqui joins us now from Phoenix, Arizona. He is a former director of the Indian Health Service. And Michael, what do you remember about that project there at Rosebud and how long it took to get that facility back up and running?
Good morning, Sean, and thank you. Yeah, Rosebud was definitely a challenge at the time, and really appreciate that we were able to go in as a team. So not only did I go in as an acting chief executive officer, but we also had the support of a medical director, a chief nurse, a quality management officer, and a chief operations officer. So we came in as a team. We had a lot of support from Ms. Smith and the entire headquarters team, as well as HHS. I would say key to success there at the time was immediate outreach and partnership with the tribe. We had in the very first week that we were there about a 5-hour meeting with our tribal councils so that we could hear directly all of the challenges that were being faced. We met with staff very early on to get their perspective on the challenges. And then we rolled up our sleeves and we started to address those challenges. As has been noted, some of our perennial challenges are recruitment and retention of healthcare professionals in rural America. That is a challenge not only for the Indian Health Service, but for many of our rural communities. We also have the historic underfunding challenge to contend with. The average age of our healthcare facilities in the Indian Health Service is about 38 years. When you compare that to the private sector, where the buildings are about 11 years old, the challenge of upkeep and maintaining accreditation, maintaining OSHA and American Disabilities Act standards becomes very difficult. And so all of these things needed to be addressed, and definitely appreciated the challenge, but much more work to do for the maintenance, I know.
Michael, going back to, here it is, 70 years, 7 decades. I've been a patient of the Indian Health Service, as have every generation of my family going back to my great-grandparents. And I want to ask you, here it is, 2025. Is this the best version of IHS, what our Native people have right now, today? Or has there been a time in the past, perhaps, when there's been better funding or the agency has been better positioned to treat the healthcare needs of Native people?
I think there are definitely bright spots throughout our history that we can point back to, and the IHS was at the forefront of much of the evolution of diabetes care and treatment, breastfeeding newborns, Dr. Warren very eloquently talked through some of the healthcare conditions that Indian country has faced and how we've overcome those. So there's been a lot of benefit to the healthcare industry overall as a result of the work that's taken place within the Indian Health Service. I would say that always taking a glass half full approach. We have many sunny, shiny days ahead of us with the infancy of artificial intelligence and what we can do in healthcare to leverage technology. Indian Health Service is in the process of modernizing our information technology infrastructure and implementing a new electronic health record. What that will bring for informed decision making and improving patient care is going to be monumental. What we've been able to do with telehealth and broadening the availability of broadband in rural Native communities. I think that there's a lot of shininess to point to in the future for the Indian Health Service and our tribal partners.
Thank you, Michael. Mary Smith, back to you. I want to ask your thoughts on the spending bill that went through the Senate today, and what do you see the impact there going forward with the future of the Indian Health Service?
Well, I mean, it didn't address the Indian Health Service directly, but as has been noted on this call, many Native people get care at Indian Health Service, but many of them are also eligible for Medicare and Medicaid. And the current bill is going to, I think, restrict the criteria for eligibility for Medicaid. I think there's elements for work requirements, which I think is problematic across the entire United States, but particularly challenging in tribal communities. Some tribal communities have over 70% unemployment. So I think those things are going to be difficult to implement, and to the extent that currently eligible Native Americans are no longer eligible for Medicaid, that is a tragedy for Native Americans.
Michael, what are your thoughts on the spending bill?
Yeah, so I've not really digested it fully. However, I believe in addition to the dollars and cents that there are other things that we can do through legislation and regulation change that will expand services to our Native populations. Just recently, CMS announced that they would be reimbursing services for American Indians in the states of Minnesota, New Mexico, I believe Idaho, Wyoming, for services outside the four walls of a hospital or a health center. So those types of innovations, making some of the COVID flexibilities permanent in Indian country, are going to be extremely helpful. We've seen here in the state of Arizona and a handful of other states recent approval for reimbursement of traditional health practices that are provided within our IHS and tribal locations. So these flexibilities and expanded services are just as important as the eligibility criteria and the funding for these programs.
Okay. Mary, another interesting piece of legislation, the Affordable Care Act, was being implemented right about the time that you came in with the Indian Health Service. Can you tell us how that law changed Native health care?
Yeah, that was another avenue because part of the Affordable Care Act was the expansion of Medicaid eligibility. So many states took advantage of that. And I know that during my time, I worked very hard along with the leadership, Secretary Burwell, Deputy Secretary Mary Wakefield, and other leadership at HHS and various governors to try to expand Medicaid, particularly in states with large populations of Native Americans. But in addition, I think it's just another avenue for Native Americans to get health care. So whether you get it through the Indian Health Service, Medicare, Medicaid, the Veterans Administration, or through the Affordable Care Act, my attitude was always, if you're eligible for something, you should take advantage of it because that's what Native Americans deserve.
Let's go to the phones. This is Vi listening in Anchorage, Alaska on station KNBA. Vi, good morning. And we're running a little light on time, so if you could keep your question to about a minute or your comment, I'd sure appreciate it. But thanks for joining the show.
Good morning, good afternoon. My name is Bawanak Vaiwari from Sivokak, which is located in the northern Bering Sea. I'd like to pose a question to all the speakers. I'm an environmental health and justice community health researcher, and we need proper diagnosis and treatment of environmental health effects. We have had our own community-based project on Sivokak due to Cold War era former bases. But we now know the Arctic is a hemispheric sink for persistent organic pollutants. And now the Arctic Ocean has the most microplastics. My people have 4 to 10 times higher PCBs than the average American in the lower 48. And we're seeing health harms not only in my community, throughout the state, but across the Indian country. I've come to learn that Black-brown communities are where majority of these industries and chemical corporations and communities like mine where there's formerly used defense sites, harming and well-being of our people. So I would like to pose this question. Are you going to be incorporating and require that IHS incorporate proper diagnosis and treatment of environmental health effects?
Environmental health effects. Okay, thank you, Vi. I'm sorry, we're running a little low on time. Michael, I'd like you to field that question first from our caller. Policies and procedures with regard to environmental health impacts.
Yeah, thank you for that. And fortunately for the Indian Health Service, we have a lot of partners throughout the federal government, including the Centers for Disease Control and the Agency for Toxic Substances and Disease Registry. We also have the National Institutes of Health who fund our tribal epicenters. Each of the Indian Health Service areas has a tribal epicenter assigned to it that receives funding, and the tribes within those geographies have a lot of discretion in the research agenda and protocol for what they want to take a look at. So I believe that's ripe for environmental studies. I also want to point to the great amount of funding that Congress has provided through the Infrastructure Investment and Jobs Act to the Indian Health Service, about $3.5 billion over 5 years to really improve upon our sanitation facilities, clean water programming. So that may be another source to respond to these types of concerns.
All right, thank you, Michael. Mary Smith, I want to give you the last word. We've got about a minute before we have to wrap up, but I want to get your thoughts on what you see as the future of the Indian Health Service.
Well, I wish the Indian Health Service like a successful and impactful next 70 years after this. And I would, as Mr. Smith mentioned, the Indian Health Service is the 18th largest health system in the United States. I would like to see the funding, the staffing, facilities, and every support given to the Indian Health Service such that out of the 18 health systems, the Indian Health Service is the best health system in the United States.
All right. Appreciate all of our guests who joined the conversation today. Mary Smith, Dr. Donald Warren, Benjamin Smith, Dr. John Molina, and retired Rear Admiral Michael Yaqui. Unfortunately, we're out of time, but you can continue this dialogue if you check us out on our website, nativeamericacalling.com, or go to our social media, Facebook, Instagram, Blue Sky Threads, any of those platforms, and you can comment, post, and like. And please don't forget to join us again tomorrow for a look at the implications the U.S. Supreme Court ruling on birthright citizenship has on Indigenous people. I'm Sean Spruce. Enjoy the rest of your day.
OCO, map out your journey to mental wellness. Our culture is a source of strength as we navigate uncertainty. Need to talk with someone who can help you tap into that strength? Contact your local Indian healthcare provider. Visit healthcare.gov/coverage or call 1-800-318-2596. A message from the Centers for Medicare and Medicaid Services.
Trickster Cultural Center hosts the 11th Annual National Gathering of American Indian Veterans to honor veterans and military personnel of all cultures, eras, and branches in a native way. Trickster Cultural Center's National Gathering of American Indian Veterans is open to the public at no charge Friday, July 18th and Saturday, July 19th in Schaumburg, Illinois. More at tricksterculturalcenter.org/national-gathering-2025. Trickster Cultural Center supports this show.
Native America Calling is produced in the Annenberg National Native Voice Studios in Albuquerque, New Mexico by Quantic Broadcast Corporation, a native nonprofit media organization. Funding is provided by the Corporation for Public Broadcasting with support from the Public Radio Satellite Service. Music is by Brent Michael Davids. Native Voice One, the Native American Radio Network.